Okay, thanks, John. Hopefully everybody got their pretzel or something. Okay, and I'm going to speak this morning about small bowel bleeding, speak a little bit about more of the acute abdomen later this afternoon. I think all of us do lots of GI bleeding cases. It's a high percent of admissions, but particularly in the ER setting, it's a very common presentation. Most patients, truthfully, with GI bleeding will do okay, but depending on the series, the mortality can reach as high as 40% in patients who are unstable. Most cases of GI bleeding, particularly patients with diverticular disease, will simply stop bleeding even without any intervention, though in about 25% bleeding will recur. A critical thing for us, of course, is finding the source of bleeding and then determining how to manage those patients. And that's what I'll share with you today. We typically think about bleeding as upper and lower GI bleeding. And classically, it's been said that upper GI bleeding is outside the scope of radiology typically, and it's really for endoscopists. And our focus is on lower GI bleeding, which is distal to the ligament of Treitz. But I will tell you that these days, I think we do both upper and lower GI bleeding. It's interesting, upper GI bleeding evaluation with CT was really more important as COVID took over. Remember, in the COVID era, lots of patients had GI bleeding, both upper and lower GI bleeding, in addition to all sorts of retroperitoneal bleeds. But the endoscopist did not want to do endoscopy. And so CT became a very, very good study. And it's continued to be that because we had very good results. And I think endoscopists also appreciated the role of CT. Now, one of the challenges of CT, of course, is lots of images. You're doing dual phase acquisition, as I'll speak about. And you're typically looking at something like 4,000 or 5,000 images. But I'll show you some of the ways I think we could look at the images and be very accurate in terms of interpretation. When you look at sources of GI bleeding, from upper to lower, the main thing you think about in upper GI bleeding typically is gastric ulcer disease, though there are other possibilities, including malignancy. And very similarly, when we talk about lower GI bleeding, number one thing you think about is diverticular disease and perhaps angiodysplasia, but there are a range of things from inflammatory to ischemic to malignancies, and we need to look at all of them. As I mentioned about upper GI bleeding, the classic statement is any patient with suspected upper GI bleeds should undergo endoscopy first. It's both high accuracy in terms of diagnosis and also can often manage the patients on a single examination. And CT was considered not to be appropriate in the sense of using it for upper GI bleeding. And if you look at some of the numbers, endoscopy numbers were indeed very high. But as patients became more difficult, or as I mentioned in the AIDS era, there was lots of concern for doing endoscopy. These days, particularly with complicated patients where the concern for doing endoscopy becomes more and more, and as endoscopists get busier and busier, and it's hard to find GI endoscopists, imaging is playing an ever stronger role. When you look at imaging, there also are a number of contraindications for doing endoscopy: shock, comorbidities, hemorrhage. And again, I think when I speak to some of my colleagues in endoscopy, they're always concerned about older patients, patients with heart disease and the like. So CT as a first step works out very well. If you look at ACR appropriateness criteria, looking at some of the things, here's one for endoscopy, confirms non-variceal upper GI bleeds without a clear source. You can see CT gets an 8. 9 is the highest rating, as we know, but CT is almost at the same level of angiography, and in a sense like this, with negative endoscopy, no source, again, CT is an 8. So in general, CT is an 8, pushing up toward that 9s as we have more experience, and that indeed becomes very important. There are a number of articles written. One of the challenges about doing GI bleeding is the protocol. I think at the end of the day, when you're unsuccessful for detecting GI bleeds, it typically revolves around protocol. I'm not giving a talk in this meeting on errors and misdiagnosis, but I will say that one of the things I think we all have problems with as we get busier and busier and spend less time with the technologists, I think the quality of studies tend to decrease because of lack of input. I also think that because of COVID, remember with COVID, first there was no oral contrast because everybody had a mask. And then at the end of COVID, we ran out of IV contrast. And so there are all different protocols, and people haven't quite gotten back to how they did things pre-March 2020. In terms of GI bleeding, a lot of the articles written, including this one, made the point about doing non-contrast CT. And I'll show some examples later, but we do not do non-contrast CT. Now, the reason to do non-contrast is to look for the presence of high-density matter that might confuse you. But in our experience, by doing dual-phase arterial and venous, anything that's a bleed will always change shape and change density between arterial and venous phase imaging. So you don't need the non-contrast. People would typically do non-contrast and then arterial. No one was doing 3 phases. I think the 2 vascular phases are much better, and I'll show you why in a little bit. If you're thinking about GI bleeding, you need to give oral contrast. And when I say oral contrast, I mean water. You need to distend the stomach. 750 cc's, even over 15 minutes, works very nicely. We're going to inject IV contrast about 100 to 120 cc's at a rate of 5 cc's a second. And I think it's also very important when you analyze the images, you look far beyond the axial images. Multiplanar is very important, and 3D, particularly MIP imaging, proves to be very valuable. We'll use thin section CT, typically 0.75 every 0.5, and again, sticking with dual phase acquisition. For all of our cases of suspected GI bleeding, we'll always scan from a little above the diaphragm till the lower portion of the symphysis. So even if we suspect it's an upper GI bleed, we're still scanning. We're doing it about a 30-second delay on the arterial phase, injecting 5 cc's a second, and doing about a 70-second delay on the venous phase. And as I mentioned, we do not do non-contrast. We do not do delayed phase. You can see in these examples, one of the things you can do, as I mentioned, going beyond axial imaging, this is cinematic rendering. We've put a lot of effort into looking at the stomach, looking at gastric fold pattern. You can see very nicely here the kind of details you can get in the gastric folds by being able to simply give water, or you can use air if you want to use physies, but you can look inside and look at the fold pattern and be able to pick up even subtle lesions. Now, one of the things we also, when we think about looking at the bowel and particularly looking at the stomach, you want to look at the density of the fluid. And yes, patients can ingest material, particularly antacids, or if patients have eaten, but in those cases, the material usually is very high density, and particularly with antacids, it's usually above 500 Hounsfield units. If you look at this case, the stomach looks of high density. And when you see high density in the fluid, again, the stomach's well distended, the patient has bled. Now, it doesn't mean it's active bleeding. You got to look for a source. And of course, here you do see a little bright dot, which is a site of active bleeding. But just simply seeing high density material in stomach or small bowel or even colon is a very good sign of recent bleeding. So we do look at that very carefully. In the stomach, gastric distension becomes critical. You can see this little site of bleeding and see it very nicely as well on the MIP imaging. I do like MIP imaging. Remember, the thing with MIP imaging, it's a projection technique, but for looking for very bright structures, if you do between a 7 and 10 millimeter slab, both axially and then coronally, it works very nicely for picking up subtle bleeds. And you can see in this case as well, you can see the jet of contrast, very classic appearance of an active bleed in the stomach. From a dual phase perspective, often the venous phase will show the bleed better than the arterial phase. But I will have to admit, there's maybe one case I could think of where I didn't see the bleed on the arterial phase and I only saw it on the venous phase. But I think it's easier to see in this case, the jet of contrast is seen on the venous phase, but wasn't seen on the arterial phase. One of the other important things to think about is sometimes you don't see that active bleeding. In the first case was very easy. This patient's fluid is of high density. You can see it layering out posteriorly. But then you look at the stomach, which is well distended, and you can see there's thickening of the posterior gastric wall, which is probably better seen on a sagittal view. Again, this idea about looking at multiple acquisitions. Here you see very nicely the posterior wall. If you take that same patient and you do 3D imaging with cinematic, you can look in the stomach. There's some of the blood within the fluid. You can see the posterior wall thickening. But then if I do an anterior projection, you can see right here and here, you can see the ulcer. So one of the things we're able to do with things like cinematic rendering, and I think when I speak about AI, I'll mention it tomorrow perhaps, that AI is going to impact things as simple as 3D imaging, because right now it takes you a little bit of time to create the 3D images, and most people don't spend the time or bother to do it. But I think looking forward, AI will be able to create the right renderings, which are very variable with cinematic rendering, to be able to show you those ulcerations. So again, that should improve our ability to work on this. Now, one of the things also in terms of looking for ulceration and looking for thickening, it's a way of picking up bleeding or ulcers that will have bled even in the situations when you don't see active bleeding. And again, that becomes very, very important. Other things, we look at high density gastric content I mentioned, and again, ulcerations. So if you look at this case in a patient with suspected GI bleeding, you look at the stomach, there's high density fluid again, which means there's blood present. Now the question is, can you see an active bleed? But if you go back, you can see a little bit of free air, and it's hard to tell where this all is on the axial, but if you go from axial to coronal, you can see the lesser curvature. You can see the walls enhancing, but you see the break in the wall with the lesser curvature. There's a large ulcer here. There's focal perforation. This is an active bleed, which you don't see the active bleeding at this point. You see the blood in the stomach, but you see the ulceration. Now, can you always distinguish benign from malignant ulcerations? The answer is no. If things are bulkier, it's more likely malignant, but you really can't see that. And you can see very nicely here, the cinematic rendering really accentuates the blood in the stomach. So again, ulcer disease is very easy to see. And then, of course, by distending the stomach, there's a typical ER patient, low hematocrit, looking for a source of bleed, no specific signs. There's an ulcerating lesion in the stomach, which was a carcinoma. Again, if the stomach was not distended, you would not see that mass. Here it is on some of the coronal volume rendered views, and here it is on the cinematic rendering. This patient would then get endoscopy and subsequent biopsy. As you move down from stomach to duodenum, here's an area of high density. At first glance, you might say, well, could this possibly be something that was ingested? The stomach looked fine. There was no foreign matter in the stomach. And if you look at the MIP imaging, you could see it almost looks like contrast throughout the second through third portion of the duodenum in the C loop. But this is active bleeding from an ulcer in the patient's second portion of the duodenum. So very easy to see. Another example of that would be this case. Here's the duodenum. You see high density fluid, so you know there's a bleed, and here's the site of bleeding here. As you go to the coronal view, and this is with volume rendering, there's the blood, second through third portion of duodenum. There's the site of active bleeding, which you can see here nicely as well. So again, one of the ways of making certain you don't miss a site of bleeding is just doing multiple reconstructions. If we go to lower GI bleeding, the classic for lower GI bleeding was to do capsule endoscopy when you're uncertain of the source of bleeding. You remember going back 15 years or so, every article showed that capsule endoscopy was 100% accurate 100% of the time, and many of the articles would say that CT was not going to exist anymore in terms of looking at GI bleeding or small bowel tumors. Well, capsule endoscopy is good, but you need to look at 50,000 images. And as more experience was gotten, the accuracy is not that good. And there are many reasons why it fails, from poor prep to rapid transit time to the presence of blood. And so we see it infrequently now. The other problem with capsule endoscopy is the capsule can get obstructed, and the only way to remove a capsule is with surgery. I remember reading this case. This is a patient who had a history of a Merkel cell tumor, presented with abdominal pain and GI bleed, and you can see this obvious obstruction and this obvious mass. And I know I called up and said, okay, there's a big mass. I'm sure it's tumor recurrence and there's bowel obstruction. But somebody ordered endoscopy with a capsule endoscopy, and here's the capsule. And it ain't going to go past here because you have a large tumor. It ain't going anywhere without surgery. And here it is on the topogram. So capsule endoscopy, I think, has really lost favor. I think CT for a suspected lower GI bleeding is where things are going. The other thing, of course, about CT in looking for the presence of GI bleeding is the ability to look extraluminal. So there are many different reasons patients can have GI bleeding, and there are also many complications within those patients. And CT can provide all of that information within a few minutes. Well, capsule endoscopy will take days. And again, the false positives and particularly the false negatives. If we look at lower GI bleeding and look at all the sources, at the top of the list, depending on the age of the patient, we look at diverticular disease and angiodysplasia. And both of those, CT angiography is indeed very strong. One of the things, again, in terms of protocols, and I showed this article just to make the point again, this is 2007, which is like a lifetime ago. I forgot who was president then. But 16 years ago, the recommendation was doing non-contrast scans, which I mentioned we're not doing now. But just to show you a couple potential errors, if you look at this case, this looks like a bleed here. There's something high density. But if you look at it from arterial to venous, it's exactly the same. So if it's foreign matter, it stays in the same place for those 40 seconds. It's the same shape and the same density. And you can see here, there's one area here and one area by the cecum, stayed exactly the same. This one looks even more concerning, perhaps, in the colon, where if I told you this was a bleed, you would believe me, but this looked identical on both arterial and venous phase imaging and looked the same hours later. So again, if you're uncertain, if you're just not sure, you can always get a delayed scan. It makes it easy, but I think you're typically not going to have a problem. Ingested matter, pills are all potential pitfalls, but again, I've never seen a case with arterial and venous phase imaging with active bleeding where the bleed looked identical on both phases. I mentioned again in terms of imaging, go with arterial and go with venous. It works out very, very nicely. Now, in terms of bleeding, one of the things where CT becomes very strong is the fact that bleeding in most patients will stop. 75% of episodes of acute lower GI bleeding due to diverticular disease stop spontaneously, and only a small percent of patients will get a second bleed, forget that admission, in their lifetime. If you look at ACR criteria, again, CTA is at the top of the list, but being appropriate from a range of variants. And I won't go through that in detail, but it pays to look at that because CTA, in fact, is put above endoscopy or any other imaging modality. Now, in terms of arterial and venous phase imaging, this is an older article, but it looked at whether arterial or venous was better for detecting bleeding. I think I would agree, and this article showed the numbers to be about the same but in my experience, I think you could always see an arterial and venous, but it's very easy to miss an arterial. So if you only showed me the arterial in some cases, and I'll show you a few quick examples, you could easily miss something, where in the venous phase, you're not going to miss it. So I think the two of them together are perfect. Arterial alone is just not going to work. So if you look at GI bleeding, again, going back to the fact that bleeding will change in appearance, that most patients can be managed conservatively. If you track down from the proximal bowel, so let's say looking at the small bowel first, Angioectasia is one of the common causes. In fact, it's the most common cause of small bowel bleeding. The thing about angiodysplasia or angioectasia, depending what you want to call, it's not something that is really embolized. If patients have angiodysplasia and it's repeated bleeding, the way to really manage it is to do surgery because it's typically multifocal. It's abnormally dilated, thin-walled vessels. Now, I just want to show you why it's very easy to miss and why technique is everything. If you look at this case and you look hard, here's the patient's duodenum. There's a little bit of higher density areas that you can see right there and by the circle, okay? So you can see them. And if you look at the coronal, I think you can appreciate it more. The bowel looks a little bit thickened, and there are several high density areas. So if you look, and even over here, so if you look very hard, it's a classic presentation of angiodysplasia, but one would admit it's still somewhat subtle. But if I take that same data set and I look at MIP imaging, look how obvious it is, because now look at all of those bright dots you're seeing, the prominent feeding vessels, that's angiodysplasia. So again, it's critical to look at MIP imaging because you will miss angiodysplasia if you only look at the axials and even if you only look at the coronals. It's the MIP imaging that really gives you your money's worth. Look at these two images, right? There's the multiple areas of angiodysplasia. This is the same image on coronal. Yes, you should recognize things, but it can be hard. Now, in terms of GI bleeding, again, I do like here, you can see on the axials, you should recognize that that's blood there. There was no positive contrast anywhere. Of course, when you do the MIP imaging, you can see it very nicely. And note that the bleeding is fed by branches off the SMA. And here it is again. As you go from arterial to venous, the bleeding increases. What about this case? This is a patient with Crohn's and had atrial fib, was on anticoagulants. Is there a bleed present? Now, if you look at this, I will tell you that's a vessel, right? That's a little branching of the SMA. But if you go back, what's this dot here? Is that anything real? This is arterial phase. That's the bleeding site. And here it is on the MIP imaging. You can see it maybe a little bit better. There's a little feeding vessel. But when you go to venous, look how much more obvious it is here. And you can see it on the coronal. And again, there it is very nicely shown. So yes, it is on the arterial, but I will tell you I probably would have missed it arterial only. On venous, it becomes very obvious. We also talk about small bowel neoplasms. Now, one of the presentations of small bowel neoplasms is GI bleeding. The typical history is low hematocrit. GI small bowel tumors are often delayed in diagnosis, anywhere from 6 to 18 months. Patients present early with vague symptoms, and they're often not diagnosed because small bowel tumors in general are rare. But they are increasing in frequency. GIST tumors, which are the second most common small bowel tumors, have basically about a 4-fold increase over the past several decades. I'll just show you some examples. We think about GIST tumors in the stomach. The most common location for a GIST tumor is indeed the stomach. The second most common is going to be in the small bowel. They can be large, but they also can be small. When they're small, they're vascular and they bleed. So for example, here's a patient with unexplained GI bleeding, and here's a vascular mass in the patient's jejunum. Yes, I would consider carcinoid tumor in the differential diagnosis. Adenocarcinoma, I would say, is much less likely because I almost never see adeno bleed unless it's a big ulcerating tumor. I also would consider metastatic things like metastatic renal cell carcinoma, but just a really nice example showing on the MIP an active bleeding site. Or in this case as well, GI bleed, no known source. Here in the fourth portion of duodenum, there's an enhancing lesion, which you can see is somewhat lobular. Again, a GIST tumor of the duodenum. Or this patient presented with GI bleeding, and when you look carefully, there are enhancing lesions only about 1 centimeter in the patient's distal jejunum. You can see it nicely here, but it's easy to overlook. This patient had a history of renal cell carcinoma, had prior resection, renal cell, melanoma, lung cancer are three of the common tumors that can present with GI bleeding. The vascular lesions are most common going to be from renal cell, though melanoma can be the same, but you can see it very nicely here on the volume rendering, very nicely here on the MIP imaging. So again, on the arterial phase, you can see it well. Here it is on the venous phase. You can imagine how easy it is to walk by that lesion. If I put a circle on it, you can see it. On the venous phase, it's really difficult to recognize. So that indeed becomes very important. Now, when you go to the colon, obviously we think about diverticular disease, but there are a range of causes for GI bleeding. I mentioned angiodysplasia in the small bowel, but it's also in the large bowel. And again, it's somewhat easy to miss. If you look at this patient with GI bleeding, I'll tell you to look at the cecum, but you have to admit the cecum on those views doesn't look all that impressive. But I go from those views to 3D rendering, volume rendering, and MIP imaging. Look how obvious that angiodysplasia is. Look at all of those tortuous vessels and those multiple zones of prominent enhancement. Classic case of angiodysplasia. As I mentioned, patients with angiodysplasia, embolization is just not going to work here long term. Typically, the patient will get a right hemicolectomy in this example, which is what the patient had done. But look how extensive it is and how easy it is to miss. Now, with diverticular disease, I think one of the important things about diverticular disease, common cause of bleeding, the most common cause, but again, this idea that most patients, at some point in their life, 15% of patients with diverticular disease will bleed at some point, but the bleeding, even though when it's large, may only occur one time. So patients can be managed with support, maybe hospitalization and blood transfusions at times, but typically will not need surgery. Only about 30% of patients will present with a second set of bleeding. So indeed, CT leads to a more conservative approach. So you look at this example, again, somewhat subtle, patient with GI bleeding, and this was actually read as negative, but here initially, but here is his little dots, not that impressive, but you go 30 seconds later, look how much more impressive it is. Now, one of the things we also know is that if bleeding increases significantly between arterial and venous phase imaging, look at the change here. The angiography, if you're doing interventional procedures on this patient, the likelihood of the interventional procedure being positive is more than 50% higher. Also, one of the things by being able to define the site of bleeding, one of the advantages of CT over TAG nuclear studies is we know precisely what vessel typically is bleeding, and so angiographers, even in the face of a negative angio, will still be able to embolize. Here's another example, classic. Now, in a diverticulum, you can see it across the board here. Again, one challenge at times is diverticuli often have high-density material in them. Again, going back to measuring things, if you have an active bleed like this case, here it's only one area, so it's easy. But besides the shape changing, which you can see here, the density changes. So if you have a diverticulum with high-density contrast, on arterial phase and venous phase, it's going to stay the same. It's also typically higher than bleeding. Bleeding tends to be about 250 to maybe 350 Hounsfield units. Positive contrast, high-density material impacted in diverticuli tend to be 500 or 600. You're typically not going to see a bleed at 500 or 600. It's typically, like this case, more like 300. And again, nicely shown on the venous phase, which you can see here as well on the coronal views. Now, one thing very important to look at on patients is if you see a site of bleeding, you got to keep looking because some patients have multiple sites of bleeding. This was an oncology patient with GI bleeding, and when you start looking carefully, the patient has bleeding in the patient's sigmoid colon, which you can see here. But as you go to the next image, you also see there's areas of bleeding in the patient's cecum. So when you're doing oncology patients, particularly, you need to be really careful because these patients, particularly if they're on immune checkpoint inhibitors, get multiple sites of bleeding. So you need to look very carefully. And enterocolitis is the most common serious complication from checkpoint inhibitors, which are used in many things now. They're treated with aggressive management, but GI bleeding is one of the presentations, and it's multifocal GI bleeding. You typically won't embolize those patients. You'll typically go after doing high-dose steroids as a way of managing. I'll also end with mentioning rectal bleeding. We see that commonly, particularly in patients with cirrhosis, but there are a range of causes. Again, you can see very nicely on these images, and here you can see the prominent vessels in this patient with bleeding, very nicely shown there, and here as well. So again, I really do like the post-processing as a way of looking. And again, in the presence of cirrhosis and portal hypertension, you want to look very carefully because look how extensive the varices can be. And again, those patients are often a challenge. They have multiple comorbidities, but it is a common source of GI bleeding, again, very nicely shown in these examples. So it's a really important thing to look at very carefully. Again, one of the reasons I commented on GI bleeding above the diaphragm through the lowest symphysis is very important, and that's not going to be uncommon. Another thing to mention is, and the last thing I'll mention, is that in terms of GI bleeding, accuracy has been reported, this is a decade ago, 98%. I'm not sure it's that high, but it's probably in the mid-90% level. I think CTA is the first line for the evaluation of obscure GI bleeding. Even in patients where endoscopists want to do colonoscopy, it pays to do CTA first. If CTA is positive, then the chance of endoscopy being positive as well increases by threefold. So concluding then, CTA is the gold standard for detecting the source of GI bleeding. Again, protocol is very critical. Fast injection rates, multi-phase acquisition, and post-processing are all critical. And with that, thanks very much.